Such a kind introduction. And so the topic today I'll be speaking on is bugs or superbugs. So we are well aware of the growing microbial resistance. And long back, Sir Alexander Fleming said the thoughtless person playing with the penicillin treatment is morally responsible for the death of the man who succumbs to infection with the penicillin resistant organism. So even in the days when penicillin was the first antibiotic to be discovered, the fear of resistance was real. And now with the rapid global spread of multi and pan-drug resistant bacteria, this is a global concern. And why it is happening? We all know that. Misuse or overuse of antimicrobials will be the main cause in this drug-resistant pathogens. Now the clinical pipeline of the new antimicrobials is also dry. Not the way the antimicrobials were being churned out in last 20, 30 years, now it has reached a kind of an end stage. Only a few pass all the trials to be introduced into the market. And this leads to a huge blow to the world economy because of productivity losses, prolonged hospital stays, increased healthcare costs also. So new resistance mechanism and the global spread of MDR bacteria have intensified the need for new antibiotics. Now, one thing that we all had to practice, I mean, now also we can start, but initially when a lot of new antibiotics were being introduced and we all shifted from our old sulfacetamide, chloramphenicol and directly into ciprofloxacin, moxifloxacin, that there is something called antibiotic cycling or rotation. Okay, so it is the scheduled rotation of one class of antibiotics with one or more different classes exhibiting comparable spectra of activity. That means one time you use fluoroquinolones, other times you can use macrolides or you can use sulfa drugs. So this kind of rotation, if we practice in our clinical scenario, so this will reduce the antibiotic resistance also. And the effectiveness of antibiotics, a lot of factors decided, that is the route of administration, location of infection, nature of the pathogens. So several in vitro parameters have been used to determine the potency of antibiotics. Okay, this is slightly theoretical, but it is important to know because we keep on prescribing the antibiotics without knowing what has gone into the trial part. So MIC, we all know, minimum inhibitory concentration, but this is not all. Till now, the focus was on MIC. Now, more terms like MPC, that is a mutant prevention concentrate. That means the concentration of the antibiotic should be such that it allows no mutant to grow. This is also important nowadays, and MBC is the minimum bactericidal concentration. And one more factor is like a mutant selection window. As you can see here in the red part of the graph, this is the mutant selection window in which the susceptible cells are inhibited and the first step resistant cells are not inhibited. Okay, so this, whatever dose we are giving, whatever the manufacturing is being done, this level has to be crossed so that MPC is reached. So there are various studies showing that gram-positive bacteria are the major contribution of ocular infections, and in gram-negative Pseudomonas is the most frequent isolate. Now, being a corneal surgeon, I have come across various keratitis, some early stages, some late stages, but in all these, mind you, I am totally dependent on microbiology, and Dr. Arpan is here to give his views on these. I think these all have been sent to him only. I'll be sharing further reports here. And so many times we have found that what clinical judgment we were making, there is a total change, U-turn after microbiology. So for routine corneal ulcers, there was once a consensus that monotherapy was enough. Fluoroquinolones like third and fourth generation, like moxifloxacin or gatifloxacin, levofloxacin and basifloxacin. So many more like three advanced formulations, Gatti, Levo and Basi were available. Okay, and before this, we were using fortified eye drops, like cefazolin fortified eye drops, so that more drug reaches into the site of infection. So right now, gram-positive cocci and gram-negative bacilli, they are quite susceptible to gatifloxacin, and even the methicillin-resistant organisms, vancomycin can also be used in such patients. Now coming to multi-drug resistant bacteria, these are the most important, that is the gram-negative, Pseudomonas, E. coli and Klebsiella. Now these infections are very fulminant, they are mostly hospital acquired and they need early and aggressive intervention. So this is the case, first case reported by Dr. Arpan only. So here as you can see clinically, we were thinking that it is quite a melt and thinking about gram-negative only, and this was corroborated by the report here, which showed a mixed growth of Pseudomonas and Bacillus. Here comparatively you can see that it is resistant only to ceftazidime here. That means this patient was referred here, sorry. Yeah, this patient was referred here and he was already on fortified antibiotics. So ceftazidime, it came out to be resistant, that's why he was not responding. But he was sensitive to even simple ciprofloxacin, gatifloxacin, levofloxacin and tobramycin also. So this patient recovered quite well, although there was a thinning in the center and we had to do a glue BCL for this. Now the second case, this is interesting because he progressed within 2 days from a small infiltrate to a large one that you can see in the picture. And when we did the culture, this came out to be Pseudomonas species, and you can see here it is resistant to almost all the antibiotics, only sensitive to colistin. So this was a difficult case and this led to endophthalmitis and needed an early surgery also, vitrectomy. And but we could not save the eye. It had to be finally eviscerated. So such things, if early culture report, early intervention are done, then probably at least some, like at least anatomical we can save, if not functional. So I'll be just touching upon the topical colistin preparation because it's not very easily available. Also, this is mostly used as an systemic form only. So this systemic colistin, this is available as injection Xylestin by Cipla and many other companies. So this has 1 million international units per 75 grams and 10 ml of distilled water is added to it. And 1 ml of the above solution will be added again to the 3 ml distilled water to form 0.19% of colistin drops. Now this is not very stable, so it has to be kept in the fridge, and in 5 to 7 days this has to be again re-prepared. Now one more drug which is important here is topical imipenem cilastin combination, that is also used as a 1% topical eye drop, and again it is a systemic IV preparation. So 10 ml of sterile water in 50 mg per ml, and along with this 1 ml of this solution added to 4 ml of sterile water, and 1% is formed. Now this even has a lower stability and it is sensitive to light, so it has to be stored in amber colored bottles, and only 3 days is the stability. This has been, both the drugs have been tried for intravitreal use also, and colistin is supposed to have a better effect than the imipenem. So to conclude, rational use of existing microbial drugs is important, and we should all practice antibiotic rotation. 4th generation fluoroquinolones like latifloxacin have a broader spectrum of antibacterial activity, and newer drugs like colistin and imipenem should be reserved for MDR cases only. Thank you so much.
Thank you, Dr. Pallavi. Your timing of this talk couldn't have been better. I mean, this is there in the newspapers also, and something that's very concerning.
Yeah, actually it's a very, very important topic.
Yes. Would
and
you also say, and establishing the etiological agent also helps?
That's what, early intervention is the key to success in such patients. I mean, you should recognize that it is not responding within a day or two. So just go ahead, do the microbiology and start off with these colistin or imipenem. Thank you.
Dr. Pallavi, I have few questions.
Yeah.
Most of us have the habit of prescribing antibiotics left, right and center, like to prevent superadded infections. Like in fungal keratitis, in viral and all that, they write antibiotics to in fungal especially to prevent superadded bacterial infections. So is it actually necessary?
See, nowadays, I would say that if you even want to prescribe, because of that fear of superadded infection, you can give a very basic drug, like chloramphenicol or sulfacetamide only. They are more effective nowadays. Rather than
Chloramphenicol and
using the higher end molecules for like a broad cover antibiotic. You should not use a specialized higher end antibiotic for giving cover. So probably you can use just a plain Ciplox also, that would also be okay.
And for bacterial conjunctivitis, what do you use?
Ciprofloxacin.
Cipro
Yeah.
starting.
And gatifloxacin is also effective because the this goes down, the frequency of drop goes down. That is.
But not Moxie.
See, there is an increased resistance to moxie nowadays as compared to gatifloxacin.
We done a study on conjunctival swab, then we
Yeah.
found what Dr. Pallavi is saying.
Gatti is better than Moxie.
Absolutely.
Yeah.
Start with Cipro if the
So
symptoms are less.
you would start with Cipro with a mild clinical presentation. You would obviously define it when you see it more often, and then get into the other one. If you really want to hit it first, then better.
Another basic question
Yeah, and
is,
post-operative also, here I would like to specify that we are giving combination drugs and we keep on tapering, like for phaco also, like for 6 weeks if the patient is using steroids, so they use the combination and keep on tapering. So it's better to give the steroid and the antibiotic separately, and you can like stop the antibiotic after 2 weeks or so and keep on tapering your steroids later.
Thanks, Pallavi. This
Thank you.
requires a whole session.